Okay, so you can start.
طيب السلام عليكم everyone. My name is Tariq Alhussein. I'm a cardiologist, and I would like to thank the group who made up all of this. يعني بصراحة this is a very great work that's done and led by Dr. Hatim. I would like to thank him for giving him this opportunity for all of us to interact, and we hope inshallah in the future that we will be able to interact physically rather than behind the screens. So we hope this COVID pandemic inshallah will be soon over. So I'll go through here with some ECGs along with their answers and explanation. I'm just wondering, well, how we should do it. Should I like open the ECG and let anyone comment and then give the proper answer, or just to go over them? So I'm opening this for your suggestions. So how would you like to run it?
Assalamu alaikum, Tariq.
Alaikum salam.
I think it is better to be interactive, just to ask a question and people can participate. It will be better, I think.
Okay. So don't feel shy. So it's always, don't feel embarrassed or shy. Just try to jump. Whoever opens the mic, he can just briefly introduce himself or herself and take the ECG and give us the answer. I will go over the correct answer. So we'll start with the first ECG. So anyone who wants to like to volunteer and take that one? Any volunteer, or should I pick?
I think better to pick.
I will pick up somebody.
Well, I think if you see the ECG and you try to figure it out before you raise your hand to say I'm ready, that will not work. Just jump in, say I am ready for this one, and analyze it while you are thinking about it.
So I will pick up Mubarak. Where is Mubarak? Mubarak, he disappeared. Rabah Usman.
ارجع ورا دكتور طارق لانه شكله اتحركت السلايدز.
Rabah Usman.
Okay. This ECG is sinus rhythm. It's normal axis. I noticed an abnormality in V2. There looks like a B wave.
Okay.
Okay.
You're suspecting that this is a P wave?
P wave. After the P wave, it's non-conducting B.
Okay. Anything else?
Other things, the QT interior.
Yeah.
I think it's some degree prolonged.
To some degree is prolonged.
Probably more than 50% RR interval.
Okay, great. Thank you very much. So here we can see clearly that there is a sinus rhythm. So there is P wave, QRS, and T wave. Okay, and as the doctor mentioned, there is prolongation of the QT. So roughly, when your eye hit, okay, an ECG, look at the RR interval and draw an imaginary line in the mid. If the QT past that 50% line, so it is prolonged. So by visual assessment, this is prolonged, and of course you can measure it if you wish. So in the setting of a prolonged QT, okay, this second deflection that comes in the T wave, what is commonly, rather than a PAC that can come, it could be a U wave, okay?
U wave.
So how can I differentiate between a U wave and a P wave? Usually, a PAC usually does not engage within the absolute refractory period within the QT. So most likely you see it in the last 1/3 of the T wave. In the first 1/3 or the second 2/3, usually you will never see a sinus beat. Okay, so remember this: a sinus beat will never come. Okay, a PAC may fall into. Okay, commonly it comes in the last 1/3. However, this deflection we can see it only uniform. Okay, with a clear hump in the T wave. So this is a U wave. So to make it more easier, so whenever you see the QT prolonged, okay, and you see something like this, so most of the time this is a U wave. Okay, so this is a patient with a sinus rhythm with hyperkalemia, and he has some prominent U wave. طبعا other morphologies, you may see it round clearly, okay, and then you can look at your long QT syndromes. You may see it bifid, okay, and this bifid usually in the middle, okay, and you can look at other types of long QT where you can see bifid QT. And the third one, actually, it looks like it resembles the hypocalcemia, where you can see the prolongation is due to prolongation of the ST segment. Okay, so it's a long QT with prominent U wave. Okay, so we go to next, Ashwaq Abdullah. Ashwaq Abdullah.
Where are you, Ashwaq?
Okay, Muawiyah.
Okay, this is a 12 lead ECG, which is sinus rhythm. You can see it in lead 3, B wave. Yearly transition in V2 of the R wave. The axis is left axis. I think there is problem in the leads because AVR seems positive.
Okay.
And the AVL is negative.
So
I think there is lead reversal because the R wave progression is normal. It does not seem like Tachycardia.
okay,
So
thank you. Thank you. So he got it right. So there is a sinus rhythm. What is abnormal here, you see this lead 1 and AVL, they don't look normal. Is it a left axis? So I have to ask myself. So look at the lead itself. You can see the P is inverted, T wave is inverted, T wave is inverted, T wave is inverted. So the whole lead is upside down, okay? So once you see lead 1 and AVL are upside down, look at the AVR. If the AVR is positive, it's one of two, either a limb lead reversal or dextrocardia. So how do you differentiate which is which? You look at the progression of the R wave, okay? They should get smaller and bigger down the road, and the S wave will reverse and start bigger and get smaller. So if you see this normal progression, so it is a limb lead reversal. You see the can you close the mic, please? Close your mics, please. Okay. So if you see the progression is reversed, so then we call it dextrocardia. Okay. So here the answer is sinus rhythm with limb lead reversal. Okay. Next one, I will choose Yasin. Yasin.
This is still the patient in inferior lead 2.
Okay.
AVF. I'm Ashwaq. Sorry, the mic is
Okay.
can be closed.
You are catching up, Ashwaq, no problem.
Yes, بس المايك كان مقفول. This inferior STEMI ST elevation in lead 2, AVF, lead 1,
Okay. So initially you thought of an inferior MI. Okay. So this,
with no posterior extension.
okay.
With ST elevation in lead 1 and V5, V6 with
How about V4?
V4.
I think it is a
This,
subtle
lateral
straight ST segment elevation, diffuse all over the leads.
Okay, thank you all. So now, initially, you thought of that this is an inferior MI. So 2-3 and AVF. So in an extension of an inferior MI, you may see posterior infection,
no posterior extension. Yes.
And the posterior extension, you see it by positive R wave usually,
Wave.
V1 and V2, which is not the case here. Okay, the RS ratio is within the normal. Sometimes you may see it extended laterally, so you may take off V5 and 6 with it, or posteriorly if you do extended leads. But here I start to see ST elevation in V1, lead 1. I start to see ST elevation also in V4, okay, in V3, so that it doesn't make sense. Okay, now it's starting not to make sense to me. So now I'm seeing a pattern of a diffuse ST elevation. Once I see diffuse ST elevation in somebody come with chest pain, immediately I have to look at the PR.
PR.
Okay. And I look for the PR depression, which is there. You can see clearly the PR depression. It's okay. Thank you, Doctora. Thank you. Okay, so there is clearly PR depression here in V4. Clearly, I can see PR depression very pronounced here. So it's more of a diffuse PR depression. And the only thing again is this is the PR elevation that I see it in AVR. So diffuse ST elevation, it's smiling upward with upward concavity. Okay, short QT, diffuse PR depression with PR elevation in AVR. So this is a classic case of pericarditis with sinus tachycardia. Okay, so we move to the next. So Azza Al-Kamil. Azza Al-Kamil, can you open your mic? She's not there. طيب Adam Musa. Adam.
Strange, يعني where are these guys?
Either they are shy or they are not with us. طيب نشوف غيرهم. فكري.
I'm not shy, but it is not clear for me here to comment on it really.
Say I'm here, I'm alive, and it's not clear.
Yes, I'm alive, sir. But I can't really comment on it. Sorry.
What is
have
not
sort of elevation in 2, and it's not really in 1 and AVL. There is sort of let me look at the rhythm strip if you don't mind.
okay?
There is.
I think now by mistake I showed the answer. So just briefly, so look at the baseline. In the baseline here, you don't see a clear atrial activity, okay? So this could be a baseline artifact, or it could be atrial fibrillation.
There's no view.
I look at the QRS reflexes. Are they regular or irregular? Do they appear to you regular or irregular? Irregular.
Yes.
Atrial activity that is not organized and
And there is no V wave.
So what is the rhythm here?
Atrial fibrillation.
So the baseline rhythm is atrial fibrillation.
Yes.
Okay. And then you see here the QT is not prolonged, okay? But I can see here the T wave is tall and tinted. Okay.
The T wave
That
is
it
the
is
profile.
tinted, and they use the expression that it is tinted. Okay, and it hurts if you sit in it. Okay, you lose this round, more smooth, round structure of the T wave, and instead of that, now it is tinted and it is tall. Okay, exceeding 6 millimeter and 10 millimeter in precordial leads. So that favors the diagnosis of hyperkalemia. So in the early stage of hyperkalemia, you get tall tinted T wave, okay, which is narrow based. Okay, so the base here is narrow. So this is a patient with atrial fibrillation and hyperkalemia. Okay, we move to the next. Maawiya.
This is a 12 lead ECG. The R wave, the axis look normal. Yes, axis normal. We have as if it is left anterior fascicular block, and we have 2 to 1 conduction. Either it is atrial tachycardia, or it seems like atrial tachycardia or 2 to 1 block, because we have 2 B wave followed by Chiaros's complex in the rhythm strip. But the Chiaros's complex is narrow.
You can't say there is atrial tachycardia or 2 to 1 because they are 2 different entities.
Yes.
Okay? Atrial tachycardia is not, sorry. Atrial tachycardia is a non-sinus. Okay, so you don't get a sinus wave. This is clearly a sinus.
2 to 1. 2 to 1 block.
And there is another P wave here.
One.
You see here that there is a baseline artifact. Okay, so the baseline artifact, but down the road there is 2 P waves. So this is a P wave, this is a P wave, and this is a P wave. If you follow the PP interval, you will find it fixed all through. So you have an organized atrial activity. So that's a sinus rhythm. It's not an atrial tachycardia. Okay, so that's a sinus rhythm, and there is 2 to 1 AV block. Now we move forward. The axis is more toward the left. Okay, thinking of left anterior hemi block. So what support the diagnosis of left anterior hemi block? You get a tiny R and a deep S. Okay, in the inferior leads. Okay, the R is big here. Almost this lead is isoelectric. So lead da kharaq al-qa'ida. Okay, so to call it left anterior hemi block, you need a tiny Q, tall R in V1, tiny Q, tall R in V1, tiny R and deep S's in the inferior leads. What further support the diagnosis is when I see poor R wave progression and deep S waves in V5 and 6. Okay, so all of that is not here. Okay, so this is not the left anterior hemi block. So what could be other differential for a tall QR, okay, with an R wave more than 10 millimeter in AVL is LVH. Okay, if I summate this with the S wave here, applying the Cornell criteria, it's positive for LVH. Or if I do the Sokolow-Lyon criteria, okay, by adding the S wave here and the R wave here, okay, also it will be greater than 35. Okay, so this is LVH. Okay, so that's a sinus rhythm. There is 2 to 1 AV block, and there is LVH with a baseline artifact. Okay, next one, Iman Salim.
Yes, this is B wave inversion, not sinus rhythm. There is some irregularity, and V1, V2, V3 signs of right bundle branch block. And in V4, right bundle branch block.
Okay, so there is right bundle branch block.
Yes.
And now here, what is different from this and the previous one, this left axis here is due to left
Yeah.
anterior hemi block. Okay, close your mouth. Thank you.
Yes.
So now I will show you clearly here the difference between left anterior hemi block and LVH. Okay, so remember in the previous one, if we go back, as we said here, this is LVH. Now let's move to this one. So there is tiny R, deep S in the inferior leads. There is tiny Q, tall R in lead 1 and AVL. Usually the R in AVL is greater than the S in lead 2. So لغاية هنا يعني all the rules are there. Okay, the R wave progression, okay, you look at the initial R is small and there is deep S waves in V5 and 6. طيب الاس waves دي ما كانت موجودة في preceding ECG. So that's a classic left anterior hemi block. There is also right bundle branch block, which is typical. RSR pattern in V1, QRS more than 120, slurred S uptake in V5 and 6, and also in the high lateral leads. You see the S wave is slurred. Okay, so that's a left anterior block and a right bundle branch block. Now let's look at the original rhythm here. So the rhythm here is the question, is this a sinus rhythm or no? I can see a lot of artifacts here. Okay, so I try to look meticulously, do I see a clear P wave or no? Okay, so do you see any clear P wave here?
No.
Any clear P wave? So probably this is a P wave that is blunted, but if you see here, the QRS is almost organized except for this complex. It could be a PAC, okay? So most likely it's a sinus rhythm. So here, this is wrong, okay? 2 to 1, 3 to 1 high grade is wrong. So it's baseline artifact, there is sinus rhythm, left anterior block, right bundle, branch block with a PAC. This is wrong. Okay, let's do another one. Rayyan Al-Badawi.
Type is the sinus rhythm.
Yes.
Left as a deviation. And there is left bundle branch block pattern.
What is the criteria of left bundle branch block in the ECG?
White QRS.
Okay.
An M W pattern في ال V5 and V6.
طيب وين ال MW pattern?
It's not there.
So it's not a left bundle, okay? So in the left bundle, clearly, what do you get? You get a wide QRS, okay? Look at the QRS here, it's narrow, it's not wide. So once I have a normal QRS, there is no left bundle, period. Okay, if you want, you can look for other criteria of left bundle branch block as well. You need to have a negative leads, negative leads in V1, V5, V2, V3. Okay, you get tall R and ST, and the ST segment usually in the opposite direction of the QRS. So if you have here, the QRS is negative, in V1 and V3, you will have ST elevation, and the QRS orientation is positive in V5 and 6 and the high lateral lead, so you get ST depression with it. Okay, it's not the case here. There is no ST depression at all. Okay, and more importantly is the loss of septal Q waves. Okay, so this is one of the criteria of left bundle branch block. Okay, you get loss of septal waves. Loss of lateral Q waves. Okay, so you look at lead 1, AVL, V5, and V6, you will not see a Q wave with it. So they are lost. And I will show you in the coming ECGs what is the typical criteria of left bundle. So that's a fairly normal ECG. We can see clearly here the P wave is there, it's organized, there is sinus rhythm, everything looks good. The voltage is a little bit low here in the limb leads. Okay, the only abnormality here is this ST segment. It's very short, as you can see here. Okay, so دائما في قاعدة في الECG يا شباب، أي ECG تعبك You look at it, it looks normal to your eyes. You're looking there, there is nothing abnormal. Always look for electrolyte disturbance. لأنه دي أكتر حاجة بتكون tricky. طيب والاي سي جي بيكون most of the time بيكون near normal. يعني ما حيجيب لك normal اي سي جي في exam. اوكي مع انه لو جابوه we always say this. The most difficult ECG in an ECG exam is a normal ECG. Okay. So, so if you see an ECG that like this one, it's pretty normal. Nothing looks to me that is abnormal. So always look for electrolyte disturbance, hypercalcemia, hypocalcemia, hypokalemia, hyperkalemia, and all of that. Okay. So here you have an ultra short QT interval with an almost not existing ST segment. There is no ST segment here. So the ST segment is completely lost. Okay, so this is Q, R, S, and there is almost uptake to the T wave right away. So the ST segment is the segment that is, the duration of the ST segment is very sensitive to calcium change in the action potential of the myocardium. So when there is hypercalcemia, you will get it ultra short, okay, because of shortening of the plateau phase. If it is prolonged, this suggests hypocalcemia. So that's a sinus rhythm with hypercalcemia. Type next. I'll choose another one. Azza.
I can take this. This is top lead ECG, show wide QRS complex, and there is a P wave. Like sine wave of hyperkalemia.
Fascicular block.
You said hyperkalemia.
Yes.
Okay. Thank you. So the answer is correct. It is hyperkalemia. Why is hyperkalemia?
Sine wave and wide QRS complex. Short BR interval.
Short or prolonged?
Prolonged BR interval. Prolonged.
Okay, thank you. You can close your mic. Okay, so the answer is hyperkalemia. So remember, in hyperkalemia, everything gets stretched out. Okay, so the P wave usually get depressed, PR interval is stretched, QRS stretched, QT stretched, everything is stretched out. Okay, so you have a very prolonged PR interval here, and the QRS, you can get any type of block associated with hyperkalemia. You can see here, fascicular block, you may see right bundle, you may see left bundle, or you may see an unspecific delay like in this case. So if you try to fit this QRS description into a typical scenario, you will find it not fitting a typical left bundle or a typical right bundle. So it's fair to judge, and you say it's more toward the left bundle, but also it is acceptable to say that this is a non-specific interventricular conduction delay. There is also blunting of the P wave, prolongation of the PR, so there is first degree heart block. So that's a classic hyperkalemia with also sinus bradycardia. Okay. Right. Next ECG. Any volunteer would like to take it?
I can take it.
Okay. Introduce yourself, please.
This is 12. معاوية.
تفضل.
معاوية. This is 12 lead ECG, which is sinus rhythm. The axis is normal axis. There is deep T wave inversion from V2 up to V6. It is not symmetrical, narrow. It looks like there is cerebral insult. This T wave inversion.
طيب what
otherwise ما في حاجة
other than the ST segment?
There is LVH برضه.
There is LVH.
ST segment is depressed, yes.
Okay. So يعني here, once you see this giant fusion, okay, of the QT, and you see this ST segment depression and this bizarre T wave, the differential between cerebral insult and apical HOCM. So how to differentiate each? Most likely in apical HOCM, you see a very high voltage criteria, okay? So this is a very significant voltage, okay? That is there in V3, V4, and V5 and 6, okay? And as you know, the V3 and V4, 5, 6, they face the anterolateral wall and also the apex of the heart. So that's an abnormal voltage. That's a super abnormal voltage. Yani look at the V5. This is a very high voltage. Okay, so that's an apical HOCM. لو وجدت ما في عندك مثلا، طبعا الهيستوري بيساعدك always، لكن لو ما وجدت اي voltage criteria, significant voltage criteria, you may call it cerebrovascular accident, or if you find the voltage criteria, it's apical HOCM. So that's a sinus rhythm with apical HOCM. Okay, ناخذ محمد. محمد. اي حد نقول اسمه ما يجاوب I will ask حاتم to kick him out.
Okay, Dr. Hatim, I can take this patient.
Can you introduce your name?
I am Yasin Isa.
طيب تفضل.
Okay, so this 12-lead ECG showing wide complex tachycardia. It looks regular, wide complex tachycardia. I think regular, and there is the axis is left axis deviation. The AVR is positive, and there is the concordance. I think it's concordance except V6. So the axis is negative, it's from inferior going toward V1 and AVR. So we have left axis deviation with negative inferior leads and positive AVR and V1. So this is most likely is going with VT. But in the rhythm strip, unfortunately, it looks irregular. So for me, my diagnosis is pre-excited. No, for me, it is a VT. It looks pre-excited AF, but
there is a delta wave, yes.
Delta wave, where delta wave?
Look
So,
at V2 and V3.
Thank you all. You can close the mics. You did very well. Okay, so it's a very wide QRS. It's the hallmark. It's very irregular. Okay, طبعا أي VT in general, 90% of VTs at the beginning, okay, in the first 30 seconds, usually they are irregular and they organize later on. But so a VT can appear like this. But what is unique about this ECG is the variable RR, okay, and the variable QRS duration. So look at the QRS duration, okay? So the QRS here is narrow, here is getting wider, and there is what looks like a delta wave here, okay?
Yeah.
So once you... Dr. Tarek, salam alaikum.
Alaikum salam.
I'm Dr. Muhammad. Unfortunately, I try to reply, but I get difficulty with the muting of sound in my phone. But I hear you that you told Dr. Hatim to take me out. So I'm sorry for that, but this is a technical issue.
I'm not going to kick you out, خلاص. Fix your mic.
Yeah, difficulty with unmuting.
خلاص نخلي لك الاي سي جي الجاي ماشي. So this is a wide complex QRS tachycardia, completely irregular. So it could be VT in the very early phase. It could be atrial fibrillation with SVT, or it could be atrial fibrillation with WPW, which is again, it is an almost pre-excitation. So what is the unique about it is the delta wave. So there is variable population of the QRS, okay, and in between you say slurred uptake of the delta wave here. So this is W classic.
Exactly F. Okay.
Okay.
Excuse me, Isaiah.
What?
Excuse me.
Yes.
In this last ECG and the rhythm strip, as if there is a capture beats or fusion beats.
طبعا this is good observation. You can see in between here some narrow complex QRSs here. Okay, this is very normal when you have atrial fibrillation. Okay, you will get the atria is the atrium will pace at what rate? Usually it's at 400 rate, but in between some sinus beat, they may find their way downward. Okay, so these sinus beat find their way downward and they can choose which track to go. Either they go through the accessory pathway or through the AV node. So they will go through whatever they find it in still in the refractory phase. Okay, what is engaged with an action potential will be blocked. So in between, you may find some P waves. They find their way down the road, okay, and they get conducted normally and give you this capture beat. Okay, so in WPW atrial fibrillation, normal observation to see some capture beats, but unlikely you will never see a fusion beat. Okay, because here you don't have a rhythm that is coming from the okay. So capture beat you may see it, but fusion beat physiologically cannot happen in this type of arrhythmia. We go to the next. This we will give it. محمد في عندنا محمد's ايفون. محمد's ايفون. طيب نشوف فكري.
Okay, there is sinus rhythm, there is B wave, there is ST segment elevation في inferior leads 2, 3 و AF. There is ST depression في V2, 3 and 4. So I think the one on AVL is sort of not clear also. Most probably it is inferior ST with posterior extension. Most probably, if I'm not mistaken, it's more on RCA than LCX because the lead one on AVL, if I'm not mistaken, sorry, that's all I can say.
طيب thank you doctor. طيب avoid close all your mics please. طيب دائما يا شباب avoid الاوفر كودينج. طيب over coding. يعني once you go and talk about LCX RCA معناه انت وصلت مرحله. طيب you are showing the examiner that your knowledge in ECG is so deep to the degree that you can tell which coronary artery is involved. ودي حتحطك في ورطه always. Okay, لانه حيسالك يقول لك how would you differentiate. Okay, it's not about lead one and AVL, so always avoid the overcoding. What is clear here, there is ST elevation, as you said, there is 2, 3 and AVF, so it's an inferior MI. Once I see inferior MI in the ECG في 3 حاجات فتش عليها. فتش على الار في involvement، فتش على الposterior extension، وفتش على AV blocks. Remember الثلاث حاجات دول. Okay? Remember it very, very, very well. And if you are doing echo for those patients, look for MR and look for RV infarction. تمام؟ So inferior MI عندي 3 حاجات I have to exclude it. RV involvement. كيف ال RV involvement? Usually it will appear as an isolated ST elevation in V1. Okay? This will favor a possible RV involvement. The posterior extension بشوف عندي positive RS ratio في V1 and V2 and V3. Okay? With ST depression. اللاترال extension طبعا في الهاي lateral leads والlow lateral leads بشوف فيها ST elevation. And I can do طبعا ال V3 V4R وبعمل ال V789 posteriorly to confirm it. أهم حاجة I always look for it اللي هي ال AV blocks. طبعا all degree of AV blocks they can appear in a person coming with an inferior MI. They can come with first degree heart block, they can come with second degree, they can come with third degree. So I look at the rhythmic strip. In this rhythmic strip, I see group beating here. 3 beats together. Once you see group beating, it means most likely you have an abnormality, okay? It's either a sino-exit atrial block or an AV block. So I look for the P wave. So if you look here, this is the P wave conducted. Second P wave conducted and is slightly prolonged than that P wave. Okay, another P wave is also the PR is getting more prolonged, and then drop and then a pause. Okay.
Yes, this is more big cells.
Progressive PR elongation. So this is Mobis type 1. Okay.
Yes.
موضوع ال RCA LCX. This is a very ECG is sensitivity for differentiating is very. The ECG in general is less sensitive to tell you which is which. You can lead 3 and AVF. Usually, if they are more with ST elevation rather than lead 2, this favors in يكون RCA. لكن again, this is not the ECG is not sensitive enough to tell you what are the differences.
Okay, thank you.
طيب, next ECG we'll give it to. طيب في ناس ما تكلموا نهائيا. في هواوي. مين هواوي ده؟ هواوي.
Sinus rhythm ECG regular. There is right bundle branch block. Positive R wave in AVR.
طيب, thank you, Dr. Close your mic, please. So this is sinus rhythm, okay? And you can see the P wave is little bit prolonged here with biphasic appearance, okay, here. So there is suggestive of left atrial enlargement. How is the PR? The PR is slightly prolonged, okay? So there is a probable also first degree AV block here. Look for any other P waves. I don't see a clear.
Can I say something, Dr. Tarek?
تفضل.
We can see also in this ECG AVL criteria of LVH, and also if you see V1 and V2, also it goes with right ventricular hypertrophy. Most probably this patient has right ventricular hypertrophy.
Okay, thank you very much. Okay, so as he mentioned here, so طبعا عشان not to miss, thank you for this point, and you are right. Okay, but when you read the ECG, we have to read it systematically. Remember, for all of you. Okay, so once you're done with the P wave and all of the PR interval, then go to the your axis and the QRS. So if you look the axis is more toward the left. Okay, what's causing this left axis? You can see the voltage across the whole ECG is high. Okay, so applying all criteria are positive. The Cornell, the Sokolow-Lyon criteria is positive for LVH. The R here is exceeding 7 millimeter. S is very deep and wide. There is ST depression here and strain also. This favors also the diagnosis of RVH on top of that. Okay, so there is first degree AV block. There is biventricular hypertrophy. There is also right bundle branch block, and the ST segment changes are due to strain because of the biventricular hypertrophy.
Excuse me, Dr. Tarek, if possible, for the ECG.
What?
Excuse me for the previous ECG. Just I want to ask for some point.
Yes.
I am Yasin.
Further.
We see there is, as you mentioned, feature of right bundle branch block, and the axis is most likely on the left. So maybe left axis deviation, and the PR interval is prolonged, first degree AV block. if I said this is trifascicular block, is it wrong?
Trifascicular block is when you have a left anterior hemi block. Okay. But again, هنا left axis is not due to left anterior hemi block. Please close your mics, please. Those who are opening the mic. طيب. So اللي خرق القاعدة هنا اللي هو diagnosis of left anterior hemi block, which is not there. ليه؟ لأنه ما عندي tiny R with deep S. Okay. The R are big in the inferior leads. The progression of the R wave is good. طيب. Actually, the voltage is high. It's not a poor R wave progression. Okay. So there is no left anterior hemi block. So لما يكون ما عندي left anterior hemi block ما أقدر أقول عليه trifascicular. لأنه trifascicular it's a combination of first degree heavy block, fascicular block, and branch block.
Okay, thank you.
طيب, take this. I will be back in just 1 minute. You can all have a look here until I come back. Just a second.
And just to remind you, يعني يا شباب, this ECG, you should always go systematic. That is better because the anchoring and premature closure biases are a lot. Yani sometimes you snatch the biggest abnormality, but you miss the rest because you prematurely close this ECG and you anchor on that. So if you go systematic, you are unlikely to miss even the trivial subtle abnormalities, which is the way in the exam is to stuff the ECG with as many abnormalities as possible and to grasp it all. And even in real life, you sometimes have like inferior MI with posterior extension. Okay, and like the vast majority will miss the posterior extension just because they are focused on the inferior. Okay, so if you go systematic, you are unlikely to miss.
طيب يا شباب, anyone would like to take this one?
Yes, I can take it.
Yeah, I can take it. Okay. Yeah. I can see from this ECG, it's the sinus rhythm with the deep S in lead 1 and tall R in AVR with negative in AVL with a poor R progression from V1. Only if we go march to V2, V3 to other poor progression of R wave. So most probably this patient has Tachycardia.
Excellent, thank you. So this is دي اللي هي زي الأولى اللي جبناها كانت limb lead reversal. Okay, one AVL are upside down, AVR is all the way up. Okay, so the diagnosis is either limb lead reversal or dextrocardia. You look for the progression, and the progression here is inversed. Okay, so that's a dextrocardia. Thank you. Type. Who would like to take this? إجلال.
Yes, I can take it.
إجلال.
I can take it.
مين معي؟ What's your name?
Yeah.
Introduce yourself.
Okay. This is ST segment elevation with right bundle brush block pattern from V1 up to V3 with reciprocal change in the inferior lead. This for anterior stem ST segment elevation, anterior MI.
Okay, so it's an anterior. What type of anterior MI?
Extensive anterior MI, which the right side, the right bundle brush block pattern is in favor of proximal LED lesion.
So the anterior, we have anterior septal. Okay, when there is V1 to V3 ST elevation. If it's up to V4, we call it anterior. V5 and 6, we call it anterolateral. If it's taking lead 1 and AVL, you may call it an extensive anterolateral STEMI. Okay, so this is an anterior STEMI because it's up to V4, and there is a right bundle branch block along with it. Okay. Right, next.
Can I take it?
تفضل.
From this rhythm strip, we can see there is two B wave. One of them, the first one was drop, and the second one was conducted. And also a little bit, يعني most probably this is caused with Mobis type 2.
But there is variable
complete
BR
complete
interval.
hard block.
It is complete hard block.
Okay, thank
Yeah,
you.
there is AV dissociation.
Yeah.
Okay, so the whole point here is to always look for, initially you thought that this is, okay, Mobis degree block, but look here, you can see this P wave, okay?
Yeah, last.
Look, it's very short, يعني it's almost يعني جاية مع الكيو ار اس لاحمين مع بعض. This cannot happen physiologically. So that P wave did not conduct and made that QRS. Also the same for this P wave. So there is something abnormal. So always I look for the QRS. The QRS is fixed, it's narrow, so that's an escape rhythm. So here you have AV dissociation. You have an independent atrial pacing and an independent ventricular pacing, and the PP interval is fixed, QRS interval is fixed, heart rate is less than 40. So all of this is complete heart block.
Yeah.
Right. Next ECG.
Yes, I can take this.
Let me pick up one. Suhair Usman.
Yeah.
Suhair. Suhair. طيب هبة خليفة. هبة خليفة. وين الناس دي؟
السلام عليكم.
تفضلي.
معلش I just joined. It's okay. This is a 12 lead ECG. It's showing paced rhythm. It looks like just a minute. This is maybe single chamber or just I think this is a single chamber VVI mode.
Okay.
There is also.
So in this is a very bizarre QRS. Okay,
yes.
that's normal. So once you see a very bizarre wide QRS, look for pacer spikes. You can see clearly here that there is pacemaker spikes, and after each spike there is a ventricular complex. Okay, so that's ventricular complex. Before that, I look for the P wave. These are the native P wave that's normally conducting. Okay, so it's atrial sensing ventricular pacing. There is no problem. There is no failure. With every spike, there is a QRS complex. Okay, so this is a normal paced rhythm without any problems. Problems.
Is it
Dr. Tarek, in V1,
the
BR different. Can you?
Yeah.
In V1, BR, أول بيس to spike.
Yes.
Different.
هو usually the setting for the ventricle, once it sends the atria, okay, it's set to a limit to start the pacing. Okay, so as long as the pacemaker is pacing at a normal rhythm, at a normal rate, so most likely there is no problem with it. Okay, but this variation can happen normally.
Delay.
Yeah. Okay.
But I think there is no consistent P waves in all the leads. So is it dual chamber or single chamber? Isn't it VVI?
Most of the pacemakers that are implanted are DDD with the ability of automatic mode switch. So if it senses the atria, okay, it can give a native QRS, okay, or it can be set just to pace. Okay, if it's not enough and there is a delay. So for you to recognize on the ECG, you have to look for the pacemaker spikes. If the spike is followed by a QRS or no. Okay, or if you get sensing normal native rhythm and it's set to pace intermittently. So for this pacemaker, it's there is no problem observed.
Okay.
Right, next. Rabab.
Rabah Usman. Okay. Okay. Sinus rhythm. The axis looks normal. Looks like some bradycardia. Like the QT. Okay. In V1, loss of QRS complex no. Yeah, I'm not seeing more. Looks like sinus brady.
Thank you. So as we said earlier, once you see an ECG that
hypokalemia.
Yeah, so once you see an ECG that looks to you normal, pretty normal, always think of electrolyte disturbance. Okay, so this is a fairly normal wave conducting and giving you normal QRSs. Okay, there is sinus bradycardia.
It looks prolonged QT interval.
There is prolonged QT interval. Okay, so if you draw an imaginary line crossing that, so the answer is right.
Yes. Hypocalcemia.
مين قال hypocalcemia?
No, hypokalemia.
Hypokalemia because the QT, the whole QT is prolonged and you get a very wide, shallow T wave.
There is almost a flat T wave also in some of the leads.
The T wave in hypocalcemia, the T wave usually has a normal narrow base and the prolongation is only for the ST segment. So بتكون ال ST segment هي اللي ممدودة. Okay? We will have another example for that. So in this case, the whole QT is prolonged and the T wave is very wide and shallow. This is
hypokalemia.
Excuse me, Dr. Tarek. There looks some U wave. If you look to the rhythm state.
There is also U waves here.
Okay.
So U wave زي ما قلنا دائما لما تكون عندك في الهايبوكاليميا usually U wave they become very prominent whenever you have a prolonged QT. Right, next. We will do two more because the time we are running and I have plenty more and we can try to organize with Hatim another session probably to do the rest of the ECG. So I will do two more here and then we will stop. So who would like to take this one?
Okay, I can take it.
Problem.
Muawiyah. This is sinus rhythm. The QRS complex looks okay. The PR interval is okay. There is criteria of LVH. We have AVL is more than 12, more than 11. The axis is left axis, and the T wave is a peak tented T wave, which is going with hyperkalemia. So it is, in summary, it is sinus, LVH, and hyperkalemia.
Excellent, thank you very much. So just to add on that, so with LVH, heart failure, more commonly to see left atrial enlargement. Okay, so always when you have an LVH with LV strain, look for left atrial enlargement. If you look here, the P wave is bifid. It's wide, more than 3 millimeter. And the second deflection is more than 1 millimeter in depth and in duration. So this favor also left atrial enlargement in addition to the left axis LVH and also the hyperkalemia because of the tall tinted T wave. Okay, last ECG. Who would like to take this one?
Go back again. Sorry. Can you go back again?
Yes.
Why this hyperacute T wave due to hyperkalemia? Maybe some sort of ischemia with this LVH? I don't know. Can you explain to me more, please?
Ischemia does not give you a tall tinted T wave. The tinting يعني لما تكون sharp. طيب this sharp upstrikes طيب الإسكيميا ممكن initially to give you shortening طيب
أو hyperacute T wave
give you prolongation okay but this appearance اللي هي tall tinted طيب شوفها هنا عاملة زي المثلث okay this is very characteristic for hyperkalemia. It doesn't happen in any other cause in the ECG. So tall tinted T wave are almost always due to hyperkalemia.
Thank you.
And usually by definition, they should be 10 millimeter in the precordial leads and 6 millimeter in the limb leads. And it's not necessarily to see it across all the leads, okay? Like last ECG, who would like to take it?
I can take it. Okay, this is 12 lead ECG, sinus rhythm. There is SC segment elevation in inferior lead with reciprocal change in high lateral lead and anterior lead. So my diagnosis is inferior STEMI.
No, this is a paste rhythm.
Paste rhythm.
Yes, please.
Paste rhythm.
The right bundle branch of block.
But excuse me.
Yes.
And also there is
So here there is
can I say something?
In the inferior leads, reciprocal changes.
there's some sort of irregularity.
Reciprocal changes at the lateral leads, yes, the one and AVL.
Okay, so we said in inferior.
Yeah.
I think this is a paste rhythm, but usually in paste rhythm, most probably in
there's a
LBB
spike
pattern. Like in this is, it looks like an RBB pattern, maybe some sort of CRT functioning. I don't know.
A small spike before phasing QRS.
احنا قلنا يا شباب avoid the overcoding. Avoid the overcoding. Okay, لو دي spike هنا، وين السبايك هنا؟ طيب هل ده هنا this QRS would be a paste rhythm? So it's narrow. Okay, معناه خرق القاعدة. There is no pacemaker spike. This is a narrow native QRS. So there is no pacemaker. So clearly we can see ST elevation, 2, 3, and AVF, reciprocal changes. So that's an inferior MI. We said when you have inferior MI, look for the AV blocks, look for RV extension, look for other extension. So other extensions, where do I look like? I look for positive RS ratio in the anterior leads, in V1 and V2, V3, which is there. The R is bigger than the S, R is bigger than the S, R is bigger than the S. There is ST depression, V1, V2, 3. So that's a mirror image. Okay, if you flip the ECG and you look posterior extension, and also in V5 and 6, there is also an ST elevation here. Okay, very minimal. So that's an infra-posterolateral MI. Second step, I need to look for the AV conduction. Is it normal or abnormal? You can see clearly here, this is the P wave, okay? There is something here, another P wave, something here, okay, another P wave.
2 to 1 block, yes.
Okay, so this could be 2 to 1. Here it's becoming a little bit irregular. There is also baseline artifact. So this is, as I told you, it's an infraposterolateral right bundle branch block. طبعا this is very important, RSR pattern. Okay, so there is 2 to 1. There is right bundle branch block. There is inferior with posterolateral extension. Any question?
والله يا أخي very thank you sir والله العظيم.
Of course, yeah, I'll agree.
Posterior
Thank you so
or
much.
even lateral extension.
What?
Sorry, come again.
What did you say?
Any lateral extension, I said.
There is a lateral extension because in V5 and 6, there is an uptake here and early ST elevation as well. Okay. So usually a lateral في الانفيرير بتشوفها V5 و 6. ليه؟ لأنه lead 1 و AVL بيكونوا mirror image بيوروكم الريسيبروكال changes. اوكي سو ما بتشوف فيهم usually ST elevation، بتشوف فيهم usually ST depression in the setting of inferior MI. لو شفت ST elevation في lead 1 وفي AVL ومعاها 2 3 and AVF think of other diagnosis. Think of pericarditis or any other diagnosis.
Sir, just a clarification, sorry. If I have an inferior infract with elevation instead of reciprocal mirror changes at the 1 and AVL, does signify involvement of LCX?
انت شايفك مركز جدا على موضوع
لا والله I just want to clarify this because you have said never could be possible unless
ما انا I've never heard انه lead 1 و AVL anything to do with LCX and RCX.
Maybe elevated also if it is LAD type 3, which is wrap around the apex. The patient presents with anterior and inferior.
Yeah, if you have an anterior MI and there is a wrap around type 3 LAD, so as the LAD is wrapping around the apex, the more closer to these are lead 3 and AVF. So هتشوف ST elevation أكتر في lead 3 and AVF. اوكي؟
Yeah, okay. Yeah.
النورمال اكستنشن بتاعه بياخد معاه 3 and AVF أكتر من lead 2. لو لقيت lead 2 أكتر by 2/3 lead 3 and AVF may favor إن ده يكون LC.
Thank you, really, thank you, sir. You have clarified a lot of things. Thank you very much.
دكتور طارق عندي سؤال. في حاجة كمان بنشوفها في الحوادث كثيرة الهايبر أكيوت تي ويف how to differentiate من الايرلي ريبولايزيشن. شكرا.
هايبر اكيوت تي ويف early repolarization. Early repolarization بيكون J point above the baseline وبيكون عندك ST elevation معها. طيب يعني بيكون عندك J point is up. طيب بيكون في ST elevation بعد كده بيكون في عندك rapid uptake for the T wave. بينما hyper acute T wave at J point بتكون في البيزلاين وال ST segment في البيزلاين all what you see is an acute T wave. A hyperacute T wave usually as a sign of an early MI, okay, بيكون عادة الكيو معاها is short. طبعا هنا in the emergency room it's always you look at the patient presentation, okay. So يعني عادة ال early repolarization is something that is discovered only on routine. يعني واحد مثلا جاي بكف عنده pneumonia و you did for him an ECG and you show this. So it's early. لكن لو واحد جايب chest pain, okay, and you see ST segment elevation hyperacute T wave, this still could be and early MI resolution. So those are the patients you need to keep them and do repeated ECG for them in the emergency. أي سؤال تاني يا شباب؟
شكرا جزيلا دكتور طارق، جزاك الله.
شكرا جزيلا، جزاك الله ألف خير. Really it was enjoyable and interesting. Thank you a lot.
Thank you. Thank you.
شكرا دكتور طارق. We are looking for the second session inshallah to finish that.
That is too much of a greed, by the way. Oh, yeah, of course, I agree with you. Now we are gonna invest on Dr. Tarek, given his huge experience in program direction, teaching, and mentoring. And by the way, you don't hear Tarek in echo, which is his forte. You hear him in clinical cardiology and ECG. He has a lot to give us. And of course, we are gonna keep him tight to this program. Well, thank you so much, Dr. Tarek. حقيقة يعني you added a different flavor. Thank you so much.
Thank you, Hatim, for inviting me. This is a very great opportunity for us. وإن شاء الله أتمنى لكم جميعا التوفيق. I will try with Hatim إن شاء الله to organize more sessions to complete the ECGs. I think the rest of the ECGs will need another 2 talks probably to complete them. This will cover the most common that you may see in your life. And also in the future, we might arrange for other echo or any other sessions, inshallah. Thank you very much. Have a good evening. Thank you, Hatim, for the invitation.
Thank you. Thank you so much. Thanks to all of you. Let's see you next Saturday with a session about cardiomyopathy.
يعطيك العافية دكتور حاتم، شكرا جزيلا.
Thank you so much. Thanks a lot. Bye-bye.